It doesn't go in, it's just that way people who miss it can listen to it. Alright. Okay.
There's something in the middle here.
Yeah,
Trying to get it away.
That's fine. How are you? You guys want me to wait for a few more minutes or get started? That's good. Well, good morning, everyone. I'm Dr. Al Hosni. I'm one of the neonatologists, and I'll be talking today about Vermont-Oxford outcome data. There's going to be a lot of data presented here. I tried to make it as simple as possible and in the most informative way, but this is going to be a learning curve for how in the future we can do this again. So this is the outline for the presentation. I'm going to talk a little bit about the background for Vermont-Oxford, the history. Then I will be talking about the obstetric measures that's been tracked through the VAN, which going to include prenatal care, C-section rate. The antenatal magnesium sulfate use is something recently been added to the database, so we only have 1 year to present. Then I'm going to talk about chorioamnionitis, maternal hypertension, and antenatal steroids. Choreo and antenatal steroids, I'm going to talk in more details because I think it's two important outcome measures or measures. And then briefly, I'm just going to go over some of the key measures from a neonatal standpoint and finish up with any questions that you guys have. So Vermont-Oxford network was established by this guy, Jerry Lucy, who's a well-known pediatrician from University of Vermont, and he started in 1988, coming up with this idea that maybe we need to have a database for all very low birth weight infants, and really it took over from that point. Today there's 900 centers that participate in the network, and 250 of those are international centers. And you can see different part of the world are represented through the network. Something to mention about the European countries, I mean, particularly Italy and the UK are well represented in the network. They heavily participate in this. Also, Australia and New Zealand also have a great presence in within the network. So again, when you think about the network, it's not just the U.S. centers, it's also some major international centers that we are comparing ourselves to. The data is collected currently for more than 50,000 infants, and this is mainly for very low birth weight infants. So that's really a good chunk of the premature birth that's happening in the U.S. And they estimate that they have about 1 million infant in their database. So again, it's becoming more and more large database, not quite as a national database, but it's getting close to. Yes. So the participation is two level. you can participate to be part of what they call the VLBW database, which basically all infants with birth weight less than 1,500 grams, and we've been part of this since 1997. Recently, over the last 5 years, they added the expanded infant database, which basically includes all infants that are admitted to the NICU. And we participated in this in 2008. Now, the type of the NICUs that they have is also divided. You have to come up with some criteria so you can compare yourself to a similar center, and that's why they came up with this NICU typing. So type A is the NICUs that have some restrictions on ventilation and or major surgeries are not performed. Type B have no restrictions on ventilation, but major surgeries are performed. Type C, they have no restrictions on ventilations and they can do major surgeries, including CT surgeries. I'm going to get to us in a minute here. Also, when you look at yourself as a center to compare with other centers, there are different levels of comparison. So you can compare yourself to all the centers within the U.S. They have that as a separate category. You can compare yourself to all the centers within the network, keeping in mind that you're going to compare yourself to a type A and a type B and a type C NICU. So it's not really a fair comparison when you compare yourself to all the centers within the network. Or, which is more accurate, compare yourself to a similar type NICU. And that's what I'm going to mainly focus on in the data that I'm going to present. Recently, we added a new group, which is the Illinois Perinatal Quality Collaborative of Illinois, which is basically all the perinatal centers within the state of Illinois, and Cardinal Glennon is considered one of the main 10 centers. And this collaborative has been initiated a few years ago, and we have all the data for all those 10 centers that we can compare ourselves to. So that's another tool locally to compare ourselves to. Glennon and St. Mary's are considered one center, because if you think about St. Mary's unit by itself, it's going to be only type A, because we have restrictions on ventilation. We don't do any surgeries. And it's mainly the perinatal centers that provide the main volume for the Cardinal Glennon. So the decision was made to combine Glennon and St. Mary's together as one center. So when we talk about the inborn data from our center, it's mainly reflecting the St. Mary's data. Does that make sense? I mean, it's confusing issue sometimes, but and again, the data that I'm going to present, it's mainly talking about comparison with type C NICUs, similar NICUs to what we have at Glennon.
So do you think that's fair? Are there a lot of other centers out there?
Exactly. Like Cincinnati, for example. I mean, they have similar setup like we do, and that's how they participate with Vermont Oxford. Boston Children's is kind of similar way. I mean, they have a separate unit at the women's hospital, but again, their children's hospital is the main perinatal center in a way that they compare themselves to. Other centers are different, like if you think about New York and Columbia, I mean, they have women and children's hospital in the same building. So children's is the same way, like we are. So the majority of big children's, for now, yes, for now, obviously, yeah. But yeah. Again, if you're gonna look at St. Mary's by itself, then it's gonna be considered totally different NICU, and a lot of those babies are moved to Glennon already. So again, we're not missing anybody in terms of looking at the inborn data for St. Mary's. No. I mean, it is an important point. I mean, for this.
Well, the distinction is a big part, and a great part of it is to data that suggests that babies that are not delivered in a tertiary care center don't do as well.
Absolutely.
I mean, that's where it's coming.
Exactly.
So,
And we are in a way considered a tertiary level because it's the same group of neonatologists that a children's hospital that provide you the care. So,
and our thought is that we select the infants that are not, that aren't going to be born here and selectively deliver them one.
yeah.
And there are a few that they're really super acute ones that
But those are still considered inborn. Inborn meaning they are still born within the perinatal cycle.
But the question in my mind, so it's really appropriate.
Yeah.
It really makes the comparison not completely
But that's again how the major centers are participating within the network. So the outborns are basically babies that comes from outside St. Mary's to Glen. Yes. Very rarely we get babies directly admitted to St. Mary's. Or if Glennon is busy and we don't want to turn anybody away, then and we have like 32 weeker, we will say
So an overflow.
yes, in a way. But that's very rare occasion. So this is the number of VLBW admissions over the last 5 years. The blue one is all admissions, so that's inborn and outborn. The red one is mainly the inborns, the ones that are born at St. Mary's. And you can see the number on top here is the actual number of admissions each year. And you can see there is a slight trend up in the number of VLBW admissions that we had over the last few years. A breakdown of the maternal race, again mainly for the inborn admission. Black obviously is African American, the green is white, and the Hispanic is in red. And you can see there is some fluctuation, but it's almost equal that for the maternal race between the African American and the white. I mean recently maybe there has been some increase in the white, but overall I mean it fluctuates and it's almost a split, either 50-50 or 50-40 sometimes. All right, going back to the admission and the breakdown based on a weight category. So number of admissions with birth weight less than 501 grams. Fluctuation, but mainly around like 10 to 14. Not a big variation. This is for babies between 501 and 750 grams. Again, 2008 and 2009 was a little slow, but over the last 3 years we've been having at least 40 babies and higher that are within that weight category. Yeah.
So since this comes from the database, which is NICU admissions, is there a way to track this through on Oxford, what percentage of all births it is, and what percentage of all, I mean, if you all NICU admissions, but can you do it as a percentage of?
Yeah, you can. I mean, I'm just presenting an absolute number and trying to determine, I mean, if there is a trend here. But yes, you can definitely get an actual number, and if you have the total number of births, then you can determine the percent.
Our births have gone up, so what I'm trying to figure out is, I mean, our births have gone up since 2008.
From our standpoint, we try to determine, I mean, are we getting more babies that are small? I mean, that's what I'm trying to present here. And that's basically giving you an absolute number of admissions on a yearly basis.
So it's not, are we delivering more babies early? It's, are we getting more babies?
Exactly.
Right.
Yeah.
So
But we can look at...
We're attacking either a higher acuity or the actual percentage of overweight hasn't changed. And it's just that our numbers have increased.
But again, if you look back, I mean, at the first slide, oops, went the wrong way. I mean, in general, babies that are born less than 1,500 grams, there's a slight trend up. And then I'm trying to look at each year and get the breakdown for birth weight.
It's been about a 10%
Yes.
between 2010 and 2012. And how much was birth went up by about 10%?
It's about 5%, I think. Yeah.
So the babies that don't make it,
Yeah. Again, this is just number of admissions, not survival. Exactly. But this is born alive. So exactly. You counted. Yes. If you are born, like if it's fetal demise, then it's not going to count as an admission. So again, 501 to 750. 750 to 1,000 gram, be mainly 40 and higher number. No big change. 1,000 to 1,250, anywhere between mid 40s to the 60s. I mean, in 2011 we had a big surge here, but it's mainly been around like the mid 40s. And then there was a trend for a lower number of babies between 1,250 and 1,500 grams, but then last year we had again an increase to 60 babies. So again, just to give you an idea about the breakdown of the VLBW that we get and where they are in terms of the birth weight. Okay, more of the fun stuff for you guys is the obstetric measures. And again, keep in mind, we're only talking about very low birth weight infant, and we're comparing ourselves with other type C NICUs within the network. So we're going to talk first about prenatal care. And the definition for prenatal care, I mean, it will be marked yes if mother received any prenatal obstetrical care prior to the admission during which birth occurred. So even if she had one visit, that still counts as a prenatal care. I understand that's not the ultimate, way to look at prenatal care, but that's how the network is looking at it. So. And this is again the inborn data that we have here. You can see it's pretty high. 95% of the women that we deliver here had some sort of prenatal care. This is the mean for the network, so just keep that in mind. When we go through the presentation, this is the 50th percentile for all level 3 NICUs within the network. C-section rate. The Vaughan average is 70%. We are just right about 50 to 60%. Anybody less than 1,500 grams, so they don't have a limit. So 450, if they survive, they still be counted. So again, babies less than 1,500 grams. Well, the network does not, but ours is 23. If they survive, yes. Born alive, yes. It's still counted, yes. Again, the network does not have a cutoff. Well, if they are born alive, they are counted. The way you look at them from a neonatal standpoint is different because you can exclude early death, which I'm going to get to. So death that happens in the first 12 hours, you can clean that data up by excluding those babies. Yeah. But overall, I think, C-section rate is, you're not going to section 22 weeker. Well, 23 weeker maybe, but 22 weeker you're not going to section. Yeah. So this is a new measure that has been added, and I think it's going to be really exciting to look at this over the next few years. The problem, though, is that they don't differentiate what the magnesium has been used for. Any mom that receives magnesium sulfate IV, is captured here, whatever the indication is. I think, again, it's going to be important looking at this since there has been a recommendation by the ACOG about the use of magnesium sulfate for neuroprotection. So I think it's something definitely that we need to keep an eye on for the next few years. As I said, we just started this last year. This is overall the use of magnesium sulfate in our practice, and you can see the network is about like 50%, whereas here we use it almost at 80% rate. So very high use of magnesium sulfate. And if you look at different weight category here, it's really high all across, especially in this group.
Why would they have chosen that? Well, it potentially doesn't reflect the benefit.
It's really hard to extract data, and if you make it complicated, then no center is going to comply with it. So they try to make it as simple as possible.
48 hours is simple.
Is there a way to say whether or not it was used post-delivery or what?
Now that's something that we can do separately from the database. I mean, we can provide you with the babies that received it, and we can go back and look at the moms. And so that's why I said this is probably important for us in the next few years to look at this, because we can provide some of the data that we can go back and try to sort out what's the indication, when was the mag used.
Yeah, the indication might be, I think it's probably extremely.
Yeah. But I mean, I know that you guys like magnesium sulfate, but I mean, really, we are way high. We are way high. So maternal hypertension, again, it's all lumped together. So whether it's chronic hypertension, pregnancy-induced, eclampsia, preeclampsia, with proteinuria, with edema, it just, if you have a high blood pressure, it's going to be counted as maternal hypertension. Really no different compared to the network over the last 3 years. It started in 2008, so I think there was probably some problem capturing all the women with hypertension, so that's why probably we didn't have a high incidence earlier. But I think our data abstractor are getting better and better into looking this measures particularly. Chorioamnionitis, another problematic area in terms of how the network is looking at it. It's answered yes if the diagnosis has been recorded in the maternal or the infant medical records. This is their definition. Okay, so they don't go by any clinical or pathological definition. I will say though, the lady who abstracted the data for us really works hard to collect the data from the maternal chart and from the neonatal chart to make sure that she's not over looking at this issue. So she tried to look at the placental report and to try to look at the maternal charts to determine whether there is really a chorioamnionitis. So, and maybe that's why we're capturing more chorioamnionitis. If you look at the Vaughan chorioamnionitis rate, it's about 15%. Recently, we have a big jump in the incidence of chorio. Is it because we capture it better through chart abstraction, or is it really because we're seeing sicker moms? I don't know, but it's really something concerning, I think, to see this big increase in the chorio incidence. So,
remember, it's not necessarily infection, and that's particularly if she's seeking for final pathology, it's inflammation. And I think that the role of inflammation is in birth is a hot topic. So I don't know that I use it as a concern.
Well, but it's something that probably needs to be evaluated.
It's interesting.
Yeah. I tried to look at 2012 particularly, since we have that increase, and using the different weight categories and gestational age categories. And you can see there is, for the network, I mean, it's obviously high for this group, and it goes down. Whereas for us, there's a big group here that have high incidence of chorioamnionitis. Looking at it differently from a gestational age standpoint, same thing. This group and this group, groups that are above 32 weeks, have a high incidence of chorioamnionitis. Whether this is true or not, I think we need to evaluate this. And just putting those two together, again, you can see that babies between 1250 and 1500 and above 32 weeks have really high incidence of chorioamnionitis.
Can you have a comorbidity, so they could also have hypertension?
They can, but there's no way to tease that out from the data. Yes, Dr. Rama. How many patients for 2012? Yes. We had 212 babies overall, so I don't have the actual number here. But I can get that for you. I mean, it's easily obtained from the database. I'm not going to go into a lot of details, but I mean, this is looking at chorioamnionitis year by year, again, using the weight category. Again, this is Vaughan. This is our incidence, and just let you look at it here. We didn't have a high incidence to start out with. It seems like this group always stand out that they have high incidence of chorio. 2009, for some reason, was a very slow year. 2008. Moving on to antenatal steroids. Again, this is the definition that the network has, and it's if you got any corticosteroids dosing, it's counted as yes. Interestingly, they lump hydrocortisone along with dexamethasone and betamethasone. You all know this. This is the NIH consensus statement about the use of antenatal steroids. Clearly, they recommend it for pregnant women between 24 and 34 weeks. This statement is about the regimen, and I think the majority of you guys use the betamethasone. And then they have something about the repeated courses. They don't really recommend it, and it says here that there are several randomized trials in progress, and if you're going to use it in accordance with one of those trials. Again, that's the statement by the NIH. Yes. Yeah, 2000. And it was, I think, revisited. This is the revisit. The original one came in 1994 and revisited consensus in 2000. This is the Royal College of Obstetrics and Gynecology. The reason I put it there is because they have this statement about 23 weeks. And it says here, antenatal corticosteroids can be considered for women between 23 and 23.6 weeks who are at risk of preterm birth. And then the next statement, decision to administer corticosteroids at that gestational age should be made at a senior level, taking all clinical aspects into consideration. Yeah, there are 4 and 6, yes. ACOG. I was surprised when I tried to look at the ACOG consensus statement. This is what I found. It has been withdrawn, which I was not aware of. Are you guys aware of that? This is the most recent one. Yes, in 2011. Yes. So, all right. So, what is our antenatal steroid use here? This is just a big picture for all very low birth weight infant, and you can see the Vaughan rate of use is about like 80%, 85%. our use over the years has been fairly stable between 70 and over the last year we had a big increase from 75 to 85. So I think we have some improvement in the antenatal steroid use here. Looking at this more closely by gestational group, that's what I want to point your attention to.
This is below average. Your bond is the mean.
Yes.
So that's half the centers are above that red line.
That's right.
So being at the red line
is good.
Being average.
Yes. Well, 58%. Yes.
But that. We want to be.
So now before you went
No, but for steroid use,
Yeah.
we want to be above that.
where does the information get pulled from? Just
From the chart.
immediate hospitalization if they received it elsewhere before they came? Or
From
anywhere?
No, from our own records. We don't look at outside records. So whatever reflective of the outside records in our records is what we look at.
We don't put not one, but not both.
That's counted as a yes.
Any
So
steroid
any
anytime.
dose of any corticosteroids is counted as a
So
yes.
if they had 2 doses last week at somewhere else, that doesn't get
If it's noted in the chart, then it will be
Okay,
counted.
so as long as it's noted in our record.
If it's noted in our medical
And even if it was 6 weeks ago, if it was noted in the
again, if it's noted in the chart,
anytime,
yes.
Up to 34 and 6 weeks, the Royal College would be just
No, so this is for all babies that are born less than 1,500 grams.
so they're
So now I'm going to break it to you based on their gestational age. Okay, so this is again our antenatal steroid use in babies that are 23 weeks over the last 5 years. You can see, again, sorry, my pointer died. That's not going to work. So in 2011, we were just about 25% when everybody in the country was using about like 50% for those group. And then in 2012, we really went up to 60% when the national average is about 70-75%. So again, yes, the statement does not support use of steroids in 23 weeks, but you can see within the network there's really a big increase in the use of antenatal steroids in that particular group. And it's something that I think it's important to know. 24 weeks. Last couple of years, we were just getting to the national average. 25 week, we're doing pretty good, except for 2010. 26 weeks, really doing very well. 27 weeks, right on the money. 28 weeks, pretty good. 29 weeks, 2011 and 10 was not that great, but 2012 is getting better. And then this is the category for 30 and 32 weeks. You can see we are really below the national average. We are around 70%, whereas the national average in the mid-80s. And this is even bigger babies, 33 to 36 weeks. We do.
What are how many babies will be on 30 weeks in the less than 1,500?
Now, looking at this, I included all the babies, meaning even if they are above 1,500 grams, they were included.
This is just
That's exactly, this is only this group. Questions? So to summarize, I mean, again, we have increased number of VLBW admissions in the last 4 years. We have high rate of antenatal magnesium sulfate use, low C-section rate. As I mentioned to you, there is a trend here for higher chorioamnionitis incidence, especially in 2012, that I think we need to look closely at. And then antenatal steroid use is improving, especially in the 23-week. Any questions that you guys have to this point? Yep. Looking at the mortality for us. Again, this is mortality for all babies, so not excluding anybody. And you can see, really, we have a fairly high mortality rate. I mean, all across. The national average is about 15%. We are around 20%. Now, if we exclude early death, which is defined as deaths that happen in the first 12 hours, we're still about the same. We still have a high mortality rate. It's about like 12%. And this is just putting the two together to kind of get an idea about where we are. Now, you have to keep in mind, looking at this data is looking at a snapshot for each year. It's not a cumulative data. And that's probably more useful to look at, and that's why we developed this card looking at the survival data. We try to look at cumulative numbers, not just at each number for each year. And it takes a lot of effort to do that, meaning we have to extract the number of admissions, the number of survival for each year, add them up, and divide them for gestational categories and weight categories. And that's what we do almost every 2 to 3 years to accumulate this. So again, it's not something that's easily extracted from one. It has to be actively done by us. And I think that's probably more useful from your standpoints to give our patients an idea about what's the percent of survival rate.
Now, are there inclusion of babies with anomalies?
Yes, we don't exclude babies with anomalies, which is going to be really hard. I mean, if we have to do that, we have again to physically go through each chart to extract that data.
And so these are starting anybody who starts alive, or people who are alive at 12 hours?
No, this is for everybody.
Anybody born alive?
Yes.
Whether they die in the
Yes.
And I guess the one difference that I can think of is that we have, our FCI experience increasing and having a large number of babies that unexpected to survive. They may not be getting.
No, that's a good point.
They may not
Yeah.
be getting the baby born alive because they had a C-section and that kind of thing. So I mean I think, and those, when you're talking about a small number of patients,
Absolutely.
it only takes another 10 people like that to change your numbers dramatically.
And that's exactly, why we see this variability here. Because, let's say for the category of 23 weeks, you might have just 6 babies each year. And if only one of them survived, then your survival rate is really, really low. And that's why we try to add them up over the years. So the denominator is a little bit bigger, and we have a bigger patient group to look at.
And I'm assuming that when you enter a baby into the database, you must be collecting information about chromosomes and anomalies. It must be there.
Not necessarily. We collect data about major congenital anomalies, but again, it's a separate category, and you have to sort them up. Which patient of the 23 weeks had that congenital anomalies? Does that make sense?
So each case doesn't have its own composite, all-encompassing.
Not within the database. We have to tease that out. Yes.
Or it tries under 13, you know,
Yeah,
tries under
but
18.
I mean, the likelihood that those are premature babies, or the number within premature, well, not really. I don't know. I mean, I cannot say.
But I'm thinking, you know, who doesn't get steroids? It's like the CDHs aren't getting steroids. And it's hard, and the people who walk in and have babies aren't getting steroids. But
Yeah.
not many, I don't think there's any institutional bias against it. So I'm trying to figure out who are they, those 20 to 30% who aren't getting it. So,
But this is all inborn data that I'm presenting to you.
This is the important.
This is all inborn data.
steroids started before they left.
And maybe it's not coded in the chart and we didn't catch it. I mean, possibility. Again, it's really hard to make a lot of conclusions from this data unless we go back and look more in depth into what really, our data is.
It's so impressive that there's 12 data.
Yeah.
Yeah, that's definitely a concern. Now, it probably may or may not be as much of a concern in other types of mixes. Right? Although if everybody
I think everybody.
the same way, then
Exactly.
everybody's got to include. Although I guess you have a choice a little bit about who you include, right?
In terms of.
Well, you could just not put somebody in.
But that's not how the system operates. The lady who does this includes any admission.
You make a decision to participate in the type A or the C or whatever, right? And that's a center decision. So theoretically, some centers might say, you know what, we're not going to enroll our babies with a major karyotype, with a 13 or an 18.
I never thought about it this way, but I don't think centers usually pick and choose who they want to include in the database and who they don't.
But as these types of metrics are going to be utilized for financial reasons, that's not the whole of it.
That's
right. You could imagine that centers will want their NICU outcomes to look as good as possible. And
to certain extent, yes.
Right. And so they're not going to want to include babies.
But at the same time, charities. So you imagine the
Yeah. Well,
you're not going to
and there's
So
different.
should we be giving steroids to babies that are not good for babies in order to what if?
No, I mean you.
have to Maybe report in the new ethics oversight when you design it, the workaround that you have to release the line. For the information, you have to say you're giving us or no, you have to know you have to get the reason why you're how to do that.
So we won't be penalized. We
Right,
shouldn't be
it's all
penalized.
But keep in mind, you're not going to be able to get to 100%. And all centers, at least participating within that, similar to us, are not achieving it. They are around 80-85%. So, and I think we can get to that level, and we did in 2012.
I'm just thinking, I admitted a 32-weeker with lethal OI.
You're not going to give.
And induced her for maternal preeclampsia. So she gets coded as hypertension. And I certainly didn't give her steroids, and I didn't give her magnesium and neuroprophylaxis. But she gets counted
In the database, yeah.
In the database. And so as long as it reflects why it wasn't done, and we don't get dinged as a center, but here we are inducing.
Well, I don't know if there's a dinging per se. But it's just to know where you are and what your practice is, and you can look more in depth into this. Absolutely. Absolutely.
But in the big picture, you can't always understand what
Exactly.
missing pieces are.
The way I look at this is really a starting point to try to understand, I mean, what's your practice is. So quickly, I mean, just go over some of the neonatal outcome. Intraventricular hemorrhage is an important one, and this is for all IVH, meaning grade 1 to grade 4. And you can see we have fairly low incidence, just around the average for, again, all IVH. Which people don't really pay close attention to that. What people are focusing more on is the severe IVH, which is grade 3 and grade 4 IVH. And over the last 2 years, you can see our incidence is really low. In 2010, we just have a slight increase. But overall, we are below the average for that. So that's one good thing, definitely, that we always like. Cystic PVL, really variable. I mean, in 2008, we had a big number of cases. But overall, I think we are just around the average. ROP, kind of similar to IVH. We looked at ROP and severe ROP. Severe ROP is what's really more meaningful for premature babies. For ROP, our overall incidence is low, but it's really low for the severe ROP, and that's something that we have consistently seen over the last few years. NEC, really variable, but just around the 50th percentile for the majority of the time. I mean, we have slight increase last year. 2010 was a special year because it was correlated to something that we've been adding to the milk called it's a fiber that has been added to the formula that was later found out to be related to increased incidence of NEC, and it was pulled out of the market, and the FDA has a big warning about it. So we actually had 3 cases of NEC related to that. So that's why we see this big increase here. Chronic lung disease, I'm going to briefly talk about it. That's one struggle that we had in our unit. As you can see, I put the last 8 years because it has been quite dramatic increase that we saw over between 2005 and 2007. We were up to 45% when everybody else in the country were around 30%. We implemented some measures in 2007 to try to improve this outcome, and we've been fairly successful. Over the last 5 years, we've been around 30%. So it's really a big struggle for us, but it's an ongoing issue that we try to improve every year. Very good questions. Trying to pay more attention into the what we call the golden hour. So pay more attention to the ventilation in the first hour for premature babies. Emphasize the use of CPAP. If we intubate them, give them Survanta pretty early. Pay more attention to the ventilator management in the first few hours. Those are the 3 main things, and the use of caffeine also to be implemented for all babies. Those are the 3-4 measures that we have.
So those first few hours are really critical for the long.
Absolutely. They call it the golden hour. We call it the golden hour.
I always thought you meant the honeymoon, but
well, there's the honeymoon phase, which is usually 12 to 24 hours. But I mean, really, the golden hour is to try to be gentle with the ventilation, try to give them the support that they need, because it takes 6 breaths in animal model. If you give them 6 big breaths to start seeing some inflammatory response in the lung. So yeah, we're still not doing as good as we want to, but it's a step in the right direction. Chronic lung disease, that's another good question. It's basically the bottom line is oxygen use at 36 weeks corrected. That's the simplest definition. But have some But yeah,
At a year of age.
It's hard to
6
know
months.
what they look like.
at 36 weeks corrected. So again, slightly higher mortality rate that we have if you look at a year by year. Low ROP and severe ROP incidence, low incidence of IVH. Not too bad when it comes to necrotizing enterocolitis, and I mentioned to you the significant improvement in the chronic lung disease incidence over the last few years. I hope this was helpful and informative. And again, there are multiple ways to look at the data. I'll be happy to talk to you further. I mean, to see if there's a preferred way that, from your standpoint, can be more beneficial that we can talk about. And clearly, if there's any area that we think needs more in-depth evaluation, then we can provide, more information to do chart approach.
That's great, Ted.
Yeah. All right. Thank you.